It's an honor and a pleasure to introduce you today to Dr. Nastaran Foyouzi. Dr. Foyouzi is a reproductive geneticist in a burgeoning new field of reproductive genetics, of which there are less than 15 in the entire country. She is triple board certified in OBGYN, reproductive endocrinology and infertility, and medical genetics. These specialties have made her one of the most sought-after fertility experts nationwide. And today, we're going to discuss what reproductive genetics means to you getting pregnant with a healthy baby. What causes infertility?
So there are many different causes of infertility. I always look this way, that in order pregnancy happen, we need egg, we need sperm, we need healthy uterus, and we need tubes to be open. And these are the main causes of infertility. Is the tube open? Sometimes the tubal obstruction could cause infertility. Sometimes simply people have some fibroid, polyp, something that interfere with implantation. Sometimes it's a male factor infertility, or sometimes there are some hormonal imbalances, or some people, they don't ovulate. And that's the part comes when the new patient comes to us to evaluate and figure out what is wrong.
At what point should a person call about infertility?
Well, the definition of infertility is based on the age of the female. If the female is 35 and younger, a year of actively trying and not getting pregnant considered as an infertility. If they are more mature than 35, then 6 months of trying and not getting pregnant considered as an infertility. And in this situation, I would recommend to see the reproductive endocrinology infertility.
What happens during a consultation with you?
Yes, so the first consultation, the first visit is really, it's a matter of gathering information to reach to the diagnosis for the second visit and treatment options. We basically evaluate different parts of the body to find out if there is anything that we can fix. For example, we are going to check the anti-Mullerian hormone, or AMH, to see what is the ovarian reserve. We are going to check the thyroid, one of the most common cause of infertility. We are going to check the tubes through the HSG or hysterosalpingogram. We are going to check the uterus through the saline sonogram to see if it's healthy. And we are going to check the semen on male to see that if there is enough sperm to be able to fertilize the egg.
Can you explain about your holistic approach to treatment?
Thank you. That's a very, very good question. As you know, majority of fertility clinic, they are offering the mental health and also the diet as an outside referral. I thought that this is a really main part of the integration with the infertility. So I have in-house mental health expert to help the patient to go through the treatment. We know that about 50% of our patients, when they have the diagnosis, they deal with the stress and anxiety, low self-esteem, feeling negative feelings, and also the feel of shame or guilt. And these are all negative feelings, as well as us giving the hormone to stimulate them, make the situation more challenging. So having in-house the mental health would help these patients not only to go through the treatment cycle more smooth, also it will increase the success of pregnancy. On the other side of it, I have added the genetic evaluation of the enzyme. Are these vitamins that people are getting, is that enough for them? Or currently the way of practice, we are basically prescribing the vitamins to anyone. But is that person enzyme can metabolize the vitamin enough? Is the doses enough for them? We have to increase, decrease. And that's another approach that I added to my holistic approach. And this comes because of my background in genetics. Also, I have a group of the acupuncturists that we know acupuncture has a good space in success of the IVF and pregnancy. So we believe that why we should have the acupuncture only at 2 specific points of treatment. What if we offer this acupuncture throughout the cycle and continuously, and by that way we are hoping that we could basically increase the success rate. So the bottom line is I'm looking as a body and soul as a one unit, not separate. And I'm trying to bring these two together and give the good services to the patients in that way.
What exactly is IVF?
IVF stands for in vitro fertilization. So what we do is we will stimulate the ovary and we will take the egg out when they are ready, fertilize them in the dish, make the embryo and grow the embryo up to day 5 in the dish. And then after that, we are going to transfer the embryo inside the uterus.
What tests will you do to help understand the course of treatment?
It's a very comprehensive evaluation when the patients come to us. The basic, of course, as we discussed, I want to see if the ovary is working, if the tubes are open, if the uterus is healthy, if the sperm is there. But in addition to that, there are some other parts, hormonal imbalances, checking the hormones, and many other, for example, infectious diseases, the FDA requirement. We are adding a lot of other tests to optimize the fertility and also evaluate all the aspects, all the steps to be able to reach to the proper diagnosis.
Based on the results of the consultation and tests, what are the main courses of treatment that you prescribe?
So there are 3 main treatment options. One is medicated time intercourse, which suited for the people that they don't have a regular period, means that they don't have 12 periods per year or less than 12 a year. The next one is the IUI or intrauterine insemination. This could be offered to LGBTQ that they don't want to go through IVF, or some of the people that they have unexplained infertility that they could benefit from the medicated IUI. And the last one is in vitro fertilization or IVF for more complex and high-end patients that they need more complex treatment.
How many reproductive geneticists are there?
We don't know how many exactly are there, but from word of mouth between my colleagues, probably we are less than 15, 10 to 15, something around that. So that makes us very unique in a way that there are not so many of us throughout the country.
What are the genetics tests and what does each one tell you?
In the reproductive genetics, there are multiple different genetic testing. One, when the couple come to us and they wanted to have babies. So the first things that we do is a preconception genetic carrier testing. As you know, there is no pure human being. We all have 1 or 2 abnormal genes. As long as the mom and dad don't overlap the same gene, the risk of having affected baby is less than 1%. But if both of them, they have the same abnormal gene, this goes to 25%. My job is to screen the couple and become sure that they are not at increased risk of having affected kid. The second part is for people that they go through IVF and they wanted to have the healthy baby or decrease the risk of the miscarriage, people that they have recurrent pregnancy loss. Then it comes the second form of the genetic testing. We call it as a pre-implantation genetic testing, PGT. It has a different form. One is PGT-A, just looking at the general loss or extra chromosome that they are main cause of miscarriage or basically infertility. The second layer is that if both parents, when they do the preconception genetic testing, they have overlap, then we are able to add the second layer of the genetic testing on the embryo and select the one that they are not affected to transfer.
How does age factor into getting pregnant?
Women are different from men. Men have stem cells. They can make the sperm throughout their life. We don't. We are born with a limited number of the egg. Every month, hundreds of the egg will be recruited. One become dominant, the rest will die. And the rate of loss become more prominent after the age of 37. Think about it like you have a bag of money and you're taking a little every month. By time, the number will be decreased. In addition, there is a quality of the egg. We know that the good quality one that the check mark works, ovulate early in life. The one that the quality is not optimal, ovulate later in life. For example, when we are 35 and younger, about 30% of our eggs are genetically abnormal. When we get to 39, this becomes 50-50. When we get to 41, 42, 80 to 85% of our eggs are genetically abnormal. 43 and above, 99%.
Does age play a factor in the mother's long-term health?
Absolutely. So when female become more mature after the age of 45, the complication of pregnancy will be increased in a way that postpartum cardiomyopathy, miscarriage, preterm labor, preeclampsia will be increased. Growth retardation of the embryo will be increased. So that's the reason when the couple come to us and the mom is 45 or above, before offering any treatment or starting any treatment, we send them to high-risk pregnancy for basically clearance and evaluation to become sure that mom can tolerate the pregnancy.
Who should consider egg freezing?
I would recommend it to all women younger than age of 40 to freeze their egg. It empowers them. It makes the options open for them for life. As you know, we are in the time that majority of women, they are career-oriented. They want to basically move up in their job and fast-paced lifestyle. So, or they may not find on time the person who is right for them. So having the egg frozen and keeping them as a backup, it gave them an option, even if they are at the age of 45, 46, and they have frozen their eggs at the age of 32 to 33. So it will give the option of having their own baby and getting pregnant. And the success rate will be the same as the person who is at the age of 32, 33, although that the woman is 45. The egg age is important.
What can you tell me about gender selection and family balancing?
So I see many people that they want to have limited number of the kids, they want to have a family balancing, and they come to me and they ask, is that something that you do? Absolutely. I believe that in autonomy of the family. If the parents want to have the different gender and technology exists and I can help them, why not? So what we do is the couple will go through in vitro fertilization or IVF, but we do the genetic testing of the embryo. Not only we are going to find out if this embryo is genetically normal, the sex also available. So then when the couple come to me, I will say, okay, you have this many embryo that are genetically normal and these are the sex. Which one do you want to transfer? And they can choose the sex that they would like.
What are the chances of twins with IVF?
Before introducing the genetic testing to our industry, it was very high. But nowadays that we have a genetic testing and we are able to know which embryo is genetically normal and which it's not, we are transferring only one genetically normal embryo most of the time. And in that situation, about 2 to 3% chance of having identical twin. And nobody knows why, but there is a possibility, even when we are transferring one genetically normal embryo, 2 to 3% chance that this will split and give the identical twin.
What's the difference between IUI and medicated timed intercourse?
In medicated time intercourse, as I mentioned, it usually suits people that they don't have a regular period, like PCOS patient or polycystic ovarian syndrome patients, or people that they don't have 12 periods a year. So what we do, we give the medication to these people and makes them to have a regular period. And then when the eggs are ready, we will tell them to get the trigger shot to release the egg, or their body, well, it's time, is release the egg, and we will tell them, now it's time to have intercourse. It's more natural. With the IUI or intrauterine insemination, when the egg is ready, instead of telling them to have intercourse at their home, we bring them in the office. The partner will give us the sample, we prep the sample, we get the best quality sperm, concentrate them, and then we put with a small catheter inside the uterus. And that will be called as an intrauterine insemination or IUI.
What's the difference between IUI and IVF?
Thank you for asking. This is one of the frequent questions that people ask. The main difference is that in IUI, fertilization happens inside the body because the egg will be released from the ovary and wait for the sperm inside the tube. Sperm will be placed by the catheter inside the uterus closer to the egg, and fertilization happen inside the tube. Then the fertilized egg will move and will be implanted inside the uterus. In IVF, we will take the egg out, fertilize them out of the body, and make the embryo, and then we transfer the embryo. But the main difference is that when you go and do the IUI, there is no way to do the genetic testing of embryo. You will go through prenatal screening. With the IVF, we have this option to check the genetics and only transfer the embryos that are genetically normal. So it's kind of screening.
What role does mental health play in getting pregnant?
There are some data that they say that about 50% of the couple, they really throughout the fertility treatment, they feel that they are alone. They don't have enough resources. They have all negative emotion, guilt feeling, shame feeling. And this is not only comes with the treatment because we are adding some medications, uncertainty about the results, financial burden of that also added up to all of this. Even diagnosis, even when we see that there is a male factor in infertility, many women even feel the guilt and shame in themselves, and emotionally it's really stressful for both couple. And it doesn't matter you are female or male, both of them they will experience it. About 30% of the time that people stop the treatment for non-medical reason, it's because the stress is so high that they cannot take it anymore. And that will basically put them at risk for not having their dream come true.
Are there foods that women should avoid when trying to get pregnant?
Basically, healthy lifestyle. It's the most important things. There are studies that has shown extra caffeine intake, more than 200 milligrams per day, which is equal one Starbucks grande of Starbucks coffee. Or alcohol, more than 5 per week. Or recreational drugs, marijuana, all of them, it has been shown to decrease the fertility. So I would say avoid them.
Should women avoid exercise before and after IUI or IVF?
Yes. So during the IUI and IVF, because we are stimulating the eggs, the ovaries become bigger. Think about it, that in each natural cycle, 100 eggs will be recruited, one become dominant, the rest will die. During the IVF, especially, we are making all of this egg to grow. I'm not saying hundreds, but average is 10, 15, 20 eggs will grow. Your ovary is going to be big, 2 to 3 times of the size that it was. So when you are doing exercise, as you know, the ovaries are attached with one ligament only. They are going up and down, and there is a higher risk of twisting from the base and cutting the blood flow and losing the ovary. Or when they are hitting to the abdominal wall, there is a possibility of rupture. So during the stimulation, we strongly recommend to be kind with your body, no impactful exercise. Walking is okay, but listen to your body, basically.
So what options does your clinic provide for the LGBTQ community?
So the treatment option is different for same-sex female LGBTQ versus the same-sex male. For same-sex female, there are 2 options. One is to do the IUI, intrauterine insemination, using the donor sperm, or going through the in vitro fertilization. Majority of the patients that they go through the IVF, the same-sex female, one of them want to use their own egg and the other wants to carry the pregnancy. We call it as a reciprocal IVF. For the same-sex male, of course, they need to get the donor egg, and then they need surrogate as well. So this is what we are offering to them, all the services in one place. We will help them to find the right donor egg. We will help them to find the right surrogate. And many of the same-sex male, either they wanted to split the eggs and some of them fertilize with one partner, the other with the other. Some people, they say, I don't want mix the both sperm and fertilize the egg. It's absolutely their choice and their right. And but the main thing is that we are offering all the fertility treatment needs that LGBT community need.
Why do patients fly in from all over the world to see you?
I think there are two unique characteristics that our clinic will offer. One is a completely personalized treatment options. We don't look at the patients as a number. We look them as a human that needs the personalized, tailored treatment that it really fits to their physiology and to their body. The second part, unique characteristic of our clinic, is that I'm one of the few, less than 15, reproductive geneticists in the country, and even I can say in the world. So we offering the very high-end reproductive genetic services, including the sex selection, which is the US is one of the leading places that can offer the best genetic testing and even sex selection to our patients. And that I believe that make people to come to US and come to my clinic to take advantage of our specialized services.
And what do you tell women who've had recurrent pregnancy loss?
Recurrent pregnancy loss patients are very, very close to my heart. So what is the definition? If couple had the pregnancy loss 3 times back-to-back, or even 2 times back-to-back, considered as a recurrent pregnancy loss. Majority of them their concern will be brushed off. They say, oh, that was an incident, that was an accident, that's okay. But the journey that the couple go through, it's really challenging and it's really, really emotionally painful. And not looking at that part and just say, oh, it was an accident, the next one is okay, it's gonna be okay. I feel it's not fair to the patients. With the recurrent pregnancy loss, because of my genetic background, I'm able to offer them the treatment that it's really tailored to them and help them to have a healthy baby. These are not infertility patients. They can become pregnant easily. I never see them as an infertility patient. They are fertile patients that they need my help to carry the pregnancy to term. And this is my mission, to help them.
What's ovarian rejuvenation?
It's a very new science with regards to helping people that they have very low ovarian reserve. It is believed that by injecting some of the growth factors, it will increase the recovery of the egg, and these people are able to make more embryo in the setting of the IVF. When the patient comes to me and asks for ovarian rejuvenation, I always tell them this is research-based first. The second is, where are you in your decision-making? This is the last option before moving to donor egg. There are patients that they come to me and they say that I'm ready to close this chapter of my life. Then of course, moving to donor egg, it's going to be more successful, and I will direct them towards that. But there are some patients that come to me that say this chapter hasn't been closed yet. And I respect it, because for female, it is a really time-sensitive decision. I don't want any of my patients look back in 5 years and say, oh my God, I didn't turn this stone on during the time that I have an option. I wanted to give all the options that exist for them to make their decisions and either be successful or move away and close that chapter of their life.
How do you help women with cancer in their childbearing years?
Very good questions. Majority of these patients, they come to me or refer to me by the hematology oncologist or by their surgeon between the time after the surgery of taking care of the cancer before the chemotherapy. Chemotherapy is the parts that affects the ovarian reserve and potential of having kids in future. So before their ovaries exposed to the chemotherapy, we have usually between 2 to 3 weeks time that we can stimulate them, and they can go through IVF, harvest the egg. If they don't have any partner, freeze the egg. If they have a partner, make the embryo and freeze the embryo. For example, one of the example of this cancer, fertility preservation in cancer patients are in breast cancer. As you know, the incidence of breast cancer is increasing, as well as the age is decreasing of manifestation of the cancer. So from the time that they do the surgery until they start the chemo, it's a 2 weeks gap in here. And this is a time that urgently we put the patient on stimulation, and we get the egg out, either fertilize, make the embryo if they have a partner, or we freeze the eggs. And they are not like the other patients that they can wait for the lab results to come. They are emergency fertility preservation patients that we take care of them right away.